Okay, so for those that are connected, thanks to all the surgeons for what's been a difficult day as usual, such is the nature of technology, and we've seen some great demonstrations today of management of some quite difficult cases. So we thought we'd just spend a few minutes chucking around one or two cases. Shaq's got a couple and I've got a couple, just to see what individuals would do to try and solve the clinical problems that are illustrated. So we'll start off with this one. This is a patient on whom a stapes was performed. I think you can all see that. It's just a bit of constantly running video. 3 years ago, with a Cas large loop Teflon prosthesis, and there's another picture that goes with this, with the prosthesis lying on its side. And I reopened this ear about 6 months ago, and I'd just like to ask each of the panel members what they would do if they reopened an ear with a prosthesis failure like this. So maybe if we start with Chris Aldrin.
Okay, can you hear me, John?
Yes, Chris, I can hear you.
Yeah, okay. Well, the thing with these eroded incuses like this, it depends how fragile that is. Sometimes you put a new prosthesis over it and it's quite secure, and you pop a blob of cement and that's fine. And sometimes you do that and you crimp it and the end falls off. And my practice then would be to go do a malleus to pedipexy. But I think initially I would try and get another piston on there and probably would put a little bit of cement to try and stop it falling off. I can see, or I could see earlier in the video, that there's a tiny bit of perilymph pulsing at the bottom, so it looks like you're all set to put your new piston in. And I think you've talked about this before, but down at the foot plate, it's good to have a laser to actually laser away. And I generally do try to make a new stapedotomy and then use a new vein graft. So that's what I would do. I would do what it looks like somebody's about to do, put a bit of cement. But I tend to put the piston on and then put the cement on. Okay, any more thoughts on that from others? Is Professor Grolman there?
Monica, what would you do up in Warsaw?
Hello, I think I agree with Chris that actually the first thing I would think of is using a standard prosthesis and reinforcement of the clip with a bit of cement. Or the other option, or the alternative, could be the prosthesis with the ball from cords with ball joints, which we can clip on malleus handles, for example. That's two solutions I would think of.
Okay, so thank you for that.
Monica, just switch your phone off, Monica. We're a conference here. Switch your phone off.
So, okay, let's see who else is looking at the moment. Witold, in Poznan, what would you do in this situation?
So I think that I can agree with these two options presented. We will start first with a typical changing of the prosthesis first. If it does not work, we will open once again this cavity and perform the malleus tapedopexy.
Okay, thanks. So who else have we got here? Can't see anyone else. Professor Grolman, good. Oh, the Rip Van Winkle of ENT.
Before doing a malleus tapedopemy, I would consider, even in this case, because you can see that the incus is still long enough, I would consider doing a clip higher on the process. So bypassing the erosion, you can still put a clip on the proximal part and not touch the facial nerve.
Are you measuring, Wilco?
What? The speed of the connection, or the Bézier connect? Oh, there he is. Okay. Okay. Now, the whole discussion about measuring, we can talk about later, because there is definitely, if you use a vein graft, you definitely need to measure. If you don't need a vein graft, it's less precise, the length of the procedure. That's my opinion, but that's something else.
I disagree.
So Robert from the Island of Elba, what would you do?
In this case, I think there is a partial erosion of the incus. I would try to preserve the incus because in my series, if I compare my results between malleus to stapedidotomy procedure from incus to stapedidotomy procedure, the best results are obtained from the incus. So I would use the bucket Robinson type prosthesis in order to try to stabilize the prosthesis and to preserve the incus.
Okay, well, I'm jolly pleased he said that. That's exactly what I did. I repaired it with bone cement. I think that incus is still viable. You can see the vessel running down its dorsum, and we re-vein grafted, and we put a bucket down the results are fine at the moment. We'll have to wait and see whether it survives. So if somebody could press the button for the next slide.
John, can I just ask? Are you suggesting putting a bucket on the lenticular process, even though it's eroded, or are you suggesting chopping that off and putting it?
No, I put the bucket on the. I repaired it with cement, and I put a bucket on the lenticular process because I don't. There's anything wrong with the lenticular process. It's the actual shaft of the incus that's got the problem on its undersurface. And I think I've repaired it adequately, and time will tell whether it falls apart or not. But at the moment, the patient has very good hearing, so that's for another day. So, the second slide. This is just a little graphic to show, half an incus missing, and the picture on the right, how it might have happened. There's obviously a retraction. No, it's not the same patient. It just happens to be a picture that fits with the graphic. So I'd like each of you presented with this patient with the picture on the right-hand side, as indicated by the graphic. So there's a stapes present. There's a malleus. There may or may not be some ankylosis of the malleus and the incudial remnant. How would you tackle this in your department? Monica?
I guess we would go to explore the middle ear if there is no cochleaire, and be sure that that the middle ear is clean. Then we would go for reconstruction, and you can use PORP, for example, to titanium PORP, which you will clip on stapes head, and then reconstruction of the tympanic membrane with some cartilage enforcement in posterior quadrant and perichondrium on it, and that's more or less our solution for that.
Okay, thank you. What about Burkhardt in Hanover? What do you think about that, Burkhardt? What would your solution be?
Yes, can you hear me? Hello? Just a moment.
We can hear
no, can you hear me? Yeah.
Yes.
If it's possible, I would try to take out the malleus head if it's big enough for that reason. Otherwise, it's not enough for that. I would do that procedure we saw with Robert to try the silastic bending with a Vincent top. It's a very nice procedure, and I did it for some times, and it's very good working in that cases. But normally I prefer the own material if the malleus head is big enough for that. We have to measure that and try that first.
How are you going to reconstruct the drum, and what are you going to do about the attic defect?
The attic defect I would reconstruct with the cartilage coming from the tragus.
Okay, thanks very much. Chris in Wexham, the UK solution?
Yeah, I think it's pretty much like the Polish solution, actually. We would use the partial clip that I showed earlier today, the Dresden clip. I'd reconstruct the attic and the posterior defect with a cartilage island graft using the perichondrium up onto the canal wall cartilage, and I'd lay that lateral to the malleus. And it looks to me like this ear's probably got a middle ear effusion, so I'd probably put a ventilation tube in as well. So it's very much like like Monica's excellent solution.
Well, the flying stroke sleeping Dutchman assures me he gave you the inspiration for this reconstruction technique, but I've seen you do it and it looks very good. So, what about with?
I have to say that, John, I just have have to say that actually Wilco did put me onto the Dresden clip. You know, Wilco's not a very good surgeon, so he always does the easy things. And he said it worked for him, so I thought if it worked for him, it's the sort of thing my trainees might be able to do. And they're very good at it, and in fact, suddenly we found the results were good. So thank you, Wilco, it's a fantastic, it was a good tip, as so many of your tips are.
Quite often the true of great thinkers, you know. Witold, what would you do?
Well, so I think when in such a case, we have a terrible problem of the Eustachian tube, because looking into the picture of the tympanic membrane was very atrophic. So perhaps we will start by the inspection of the Eustachian tube function, and perhaps this new technique proposed by Zithoff in Germany with a tuboplasty, with a balloon, perhaps. And after this reconstruction of the reconstruction, and to close this defect, of course, we will use the palisade technique with a cartilage. So it's głosem się stało.
Yeah, it's an interesting thing with the balloon tuboplasty, because Holger's doing it on every ear case he does now. Obviously he's on commission, but you know, nonetheless, he seems to think it's a good idea. Are any of the other panel members routinely doing eustachian tuboplasty?
No, routinely.
Chris, who's moderating here?
Who's moderating? I think it's probably me, isn't it?
That's a very fair question. Yeah, who's moderating? It's a very fair question. Who's doing tuboplasty? I mean, I know Holger's travel expenses require enormous support.
Yeah. We can't transmit this over the internet.
Yeah. But it wasn't meant to be. But this is. I mean, I think this is a very interesting technique. I don't know what. I mean, Robert? What do you think? I mean, I actually think the anterior part of that ear is reasonably well ventilated now. This is probably a problem. Probably the patient had earlier. What's your solution going to be? I suspect it involves a relocation of some type.
Yeah, I would try to relocate the malleus, but maybe now in this kind of situation I would use the malleus replacement prosthesis, which I put maybe not at 12 o'clock because there's no more bone. I will see if there is enough bone. If there is enough bone, I will insert this malleus replacement prosthesis at 9, 10 o'clock. Otherwise, I will put it at 6. And then I would use the torque with the synelastic bending technique, as Burkhard said. And of course, I will reinforce the posterior half of the tympanic membrane with cartilage.
Okay, thanks.
This is what I would do.
I can see Kalga Batman is in Istanbul. Kalga, what do you think about this situation? Do you have a solution?
Hello. I came lately, so I couldn't understand the situation.
Okay, there's a posterior retraction pocket which has destroyed the long process of the incus as shown in the graphic. The patient may or may not have bad eustachian function, and we'll assume for the purpose of discussion they have a 50 decibel hearing loss with a stapes that's still present and mobile.
Well, in this case, we are on the last 10 to 12 years, we are using bone cement, glass ionomer bone cement, and we are very happy with the material. What happens in that bone cement is there are some more resonating abilities of this cement, and this cement provides a very good resolution of the high frequencies. And
can I just ask where are you going to put the bone cement? Onto the head of the stapes, or from where to where?
From long course of incus to stapes. Well, we are reconstructing the long course of incus on site, on the place. We are not removing the bone, and if the other let's say ossicles are intact, then we are only using some cartilage for the reconstruction of the tympanic membrane, where is retracted, and also we are reconstructing the long process of incus with bone cement. And
But Cochlear, are you able to reconstruct such a large defect between the incus and the stapes head with cement?
Well, could be if we can. Well, it is possible because we are using bone cement in two or three let's say stages. First we use some bone cement, wait for it, and then it freezes, and then use another portion, and then use another portion.
I see.
So we take the bone in the order that it must be.
Okay, thanks. So I think
say something?
Yeah, sure. Go ahead.
Yeah, we would do this by putting a little 5-0 vicryl on the incus, which bridges already the gap between the incus and the stapes. And then I would use not ionosement but hydroxyapatite cement to have this wrapped around this vicryl thread between the incus. So this is a way to bridge a large gap, and that is very well possible. It's no problem at all, and the results are superior to ossiculoplasty, I can assure you. And it's,
so you're going to use
surgery.
You're going to use a scaffold basically, and then build an ossicle around it with cement.
Yes.
Okay.
Absolutely.
Okay then. Right. Well, I'm going to hand over now to Shaq Said from UCL, and he's going to set a couple of questions for you as well.
Okay, good afternoon everyone. I presume you can hear me. So on the slide there you can hopefully see an otoscopic picture. This is a 33-year-old male with recurrent discharge for 1.5 years. The hearing test is essentially normal, as you can see. The opposite ear is normal. And the first question that I have for you as panelists is whether you would undertake any preoperative imaging in this particular situation. So why don't we start with you, and can you tell us whether you would do any imaging in this situation?
I would do a CT scan here. I mean, he's clearly got a cholesteatoma in his attic. The interesting thing is that his hearing is so good. So the question is how involved is his ossicular chain, and so I would do a CT. Definitely. I basically do CTs on all my cholesteatomas preoperatively, and I would be hoping with good hearing like that that was limited to the attic, and then I'd do that probably per canal and reconstruct it with cartilage. But yes, CT would be what I would do.
So on the basis that the hearing is normal, and therefore you assume that this is very localized epitympanic disease, possibly even lateral to the ossicles, what is a CT scan going to tell you that you won't be able to see when you do the operation?
Well, of course, it may not be that, and that will help me counsel my patient. So if I see that that's a small cholesteatoma on the lateral surface of the ossicular chain with a well-ventilated mastoid, then I'll tell my patients that there's a good chance I can get it out and keep the ossicular chain. If there's very extensive involvement of the mastoid with more erosion than we see, then I would counsel them otherwise, and I'd be more likely to start counselling them that I'd be doing a combined approach Tympanoplasty. It also helps me whether I'll be able to do a combined approach Tympanoplasty depending on how sclerotic the mastoid is. It'll also tell me if there are other involvement of the tegmen, for instance, or whether it's more extensive going down to the facial nerves. So I find it useful. We use them routinely in endoscopic sinus surgery. I don't see why everybody doesn't use them for ear surgery.
Okay, thanks, Chris. Now, what is the position from Hanover in terms of preoperative imaging in this situation?
It's exactly the same like Chris mentioned. We perform in every case, normally in every case, DVD scan, and the question is, of course, the same. What will that tell us preoperatively? What we could not see during the operation. But it's a question of counseling the patient. It's a question to choose the surgical way to the middle ear from behind or endoral approach. All that issues are targeted with a CT or DVD scan.
Okay. Does anyone have a different position in terms of the role of imaging in this situation?
Yes, we would not ask for a CT scan, but for a cone beam CT scan first, because even if the hearing is normal, you only see the top of the iceberg, so there could still be a large tumor behind it. I agree that probably you're dealing with a small cholesteatoma, but if you do a cone beam CT, you will see better than on high resolution CT your bony landmarks and the bony structures. And if you have any suspicion of a further extension, then I would go for an MRI, just to exclude any further either Tegman defect, even a fistula. It's still possible to have a fistula with a normal hearing. So in order to have a good preoperative roadmap, I would first do a cone beam CT and eventually later on MRI.
Okay, what about Istanbul?
Yes, thank you very much. Well, this cholesteatoma goes by the lateral wall or lateral part of the malleus. So, since it goes through the lateral part of the malleus, most probably the tensor tympani muscle, and also some there could be some problems with the facial nerve. But since it seems to be small, then maybe imaging could not show everything, but surgeon must be ready to, when opening that case, must be ready to do maybe some part of mastoidectomy also. So it is unforeseen because the beginning of the cholesteatoma is small, but well, it enlarges in the small cavities. So it could not destroy the ossicles, but it can go through the mastoid. So it is, well, it is surgeon's choice to have some maybe some techniques. But if I am going to do this patient, I will do a CISS sequence of MRI in order to obtain the whole body of cholesteatoma within the mastoid.
Okay, that's an interesting position to take. Miguel, what is your position in Madrid in terms of preoperative imaging? Can you switch your microphone on, Miguel? We can't hear you. Yeah, you should be able to switch it on from your pocket control.
On top of it.
We're still not hearing you. Okay.
I beg your pardon?
I'm just trying to get a signal from Madrid.
Okay.
Can you hear me now?
Yes, now we hear you. Yes.
Yeah, okay.
So, pre-op imaging.
Yeah, of course. For me, the only thing I know from that otoscopy is that we have a cholesteatoma, nothing else. I need much more information. I need a CT scan. There's not only the extension of the cholesteatoma, possible involvement of the ossicular chain, even though we have a very good hearing, and also the variability of the mastoid. I would like to know all those things before planning any kind of surgery. So I will not go through this case without imaging, of course, and CT scan would be my preferred first option.
So I addressed this to all the panel then. We've gone from a situation in the space of 10 years, maybe less than that, maybe a little bit more, where preoperative imaging would not be routine practice, to where everyone is now saying that it is mandatory for various reasons. Is that a consensus then, that you have to do imaging in this situation?
No. Yeah.
Okay. Would any of you like to make a statement as whether you feel it would be a reduction in standard of care if you did not do the imaging preoperatively? Chris, would you defend me if I did this operation without pre-op imaging?
Well, you know, Shaka, I would always defend you. You know that. However, and you would be okay in the UK because there's clearly a body of opinion of experienced ear surgeons who routinely do not scan. I personally think, I'm not sure that it's negligent, and I think it's defensible not to do a scan, but I don't get it. I don't understand why people don't do a scan, because it's useful. But they've done scan. What they say, these people, they say, well, we've been doing this surgery for years without scans and we've been okay. So I think it's hard to make it indefensible, but I just think it's a useful thing. And I come back to this idea of endoscopic sinus surgery. We all scan for that, and that's because it can be unpredictable and the anatomy is variable, and it's exactly the same in the ear. I was interested that some people just do MRI scans there. I must say, I think on its own, an MRI scan doesn't give you the relationship to the ossicular chain. It doesn't show you erosion of the facial canal. It doesn't show you erosion of the lateral semicircular canal. And whilst it shows the extent of the cholesteatoma, I think as a single investigation, I'm surprised that that's used. I think as an adjunct, in addition to a CT scan, it's very useful.
Okay, for the sake of time, I'm going to, could we advance to the next slide? Okay, so here we have a 37-year-old male with recurrent discharge from this ear, and whenever the ear is treated with topical antibiotics and corticosteroids, it dries up, but whenever the drops are stopped, the ear starts to discharge. And just in case you can't see clearly, there's a large central perforation with granulations in the middle ear and mucopus bathing the ear as well. The opposite ear is normal. You can see what the pure tone air conduction and bone conduction thresholds are. So the question that I have is that this patient is on your operating schedule, and you get a telephone call from the resident telling you that the ear is wet and it looks like this. And so would you continue with surgery, or would you postpone the surgery? And should we start, Monica? Let's start in Warsaw then. What's your position operating on this ear in this situation?
We would definitely do not operate on the wet ear, and in case of having this on the operating schedule, we would surely postpone the surgery. For example, having a patient for a couple of days on a conservative treatment in a hospital, and when we are sure that the mucosa is, well, at least look healthier and drier. And if we will be sure that for a couple of days it's dry ear, then we would probably, well, try to close the ear.
Is there any evidence in the literature that the outcomes from tympanoplasty in dry ears is better than the outcomes in wet ears?
Well, the evidence from the clinical experience is that if you will close the wet ear, then you have a high risk that your graft will not heal. So you face a huge, a considerable risk of failure of your procedure.
Okay, I'd be interested to see whether anyone or if people agree with you, because I'm not sure that the evidence in the literature supports that argument. Kagler, you're from Istanbul. You seem to want to make a statement.
Yes. Now, everybody prefers to do the dry ear than the draining ear. Well, in this case, if the ear drainage stops for a long time, then that could be the most advantageous ear to operate. But if it doesn't dry, then of course we are going to operate them. Then that case could be due to some bacterial biofilm, and this biofilm could not be cleaned unless you make the surgery. So it is mandatory to do surgery in that case of patients if it doesn't get dry.
Vitol, do you want to make a comment?
Yeah, so I think that in such a situation, for us, the point number one is bacteriology. Bacteriology and the examination of the bacteriology.
Biofilms.
Yeah. And we don't start the surgery in such a case because it's a simple chronic otitis media. We can wait. We don't need to start surgery. And if my resident asks me to follow the surgery to stop it, I will tell him immediately, stop it. Why you didn't perform the bacteriology before your surgery? Is my answer.
Jacques, can I speak? Can I say something?
Yes, Robert, would you continue with the surgery or would you postpone?
Yeah, it's an interesting point. We have this whole concept that we need to wait for having a perfectly dry ear, which is, I think, probably always better. But we all have patients in which we cannot dry the ear. It's still like this forever and ever, and we have to make a decision. And I must say I've done many cases like this, and the rate of success is the same as dry ear. I didn't see any difference in my hands between dry ears and wet ears like this. So I really think it's not a contraindication for me to do surgery in this case. But I would try first, of course, the medical treatment and for a few weeks, and if it doesn't stop, then I would do surgery for sure.
All right, well, let's just move on to the next slide because time is defeating us. This is, I presume that you all recognize this piece of equipment. And the question, we've touched on this during the course of the surgeries today, but my question for all of you individually is whether you use this, those of you who use this facial nerve monitoring equipment routinely for ear surgery, if you could just raise your hand. So the only response seems to be from Belgium and from the UK, and from one person in the Netherlands.
But Jacques, sorry for interrupting you, but is your question talking about every type of surgery, which means that, Chris, are you using it for every type of surgery, or?
It routinely whenever I have a drill. Whenever you have a drill in your hand, we use a facial nerve monitor, but I don't use it for a stapedectomy or for a laryngoplasty or for a sacculoplasty, but I use it whenever there's cholesteatoma, when I'm drilling, basically. And then I would use it routinely, but not for every case.
And just picking up on that then, Chris, what is the legal situation in the United Kingdom when it comes to facial nerve monitoring and ear surgery?
Well, I think it's similar to CT, but I think it's moved a little bit further. There are undoubtedly ear surgeons in the UK who've been in practice a long time who would never use a facial nerve monitor. However, my feeling is as soon as you buy a facial nerve monitor and you have it in your operating theatre, then you are obliged to use it when you're using a drill, because if you were going to court with a facial nerve palsy, if I was the lawyer, I would say, and tell me, Professor Saeed, do you have a facial nerve monitor? Yes, I have one. And what's that for? And tell me where it was at the time of the operation. Oh, it was in the box of the corner of the operating theatre. Do you think that was wise? And I suspect that would count against you. So I think if you buy one, you should use it. There's possibly a case if you're very senior and you've never used one not to buy one. But I think for new surgeons in the UK, they will pretty much all follow our sort of idea that you use a facial nerve monitor when you get a drill.
It's good you're not a French judge, Chris.
All right. If it was you, Robert, we'd have the guillotine out.
Is that Thomas in Hanover? Yes, Thomas.
I mean, your statement is quite clear that you can hear me? You can hear me? Okay. So your statement is quite clear that you always will use it. But is there any proof that it really helps? I mean, you can cut the nerve and the monitoring would not even make a beep. And it doesn't constitute your knowledge in surgery. So let's assume you come to your operating theater, Chris, and the monitoring system has gone. Somebody has stolen it, or it's dysfunctional. Would you then stop the surgery? The patient is already under general anesthesia. Would you say, no, I don't go further? I have to wait before I get it?
The questions are all coming to me. I would operate, for sure. I'd operate. If the machine was broken, I would just operate. And I completely agree with you. I've used the monitor since I have been in practice for 16 years, and I can say it's been useful
thank you, Mr. Aldrin.
probably once or twice.
I'm sorry, Mr. Aldrin. I'm speaking as a barrister here. You didn't check your equipment before you started surgery.
I've got a facial nerve palsy. I've never had a facial nerve palsy.
No, likewise, and I have the monitor in my theatre, and being one of the older, perhaps less experienced with the nerve monitor surgeons, there are rare occasions when I connect it up, and it frightens me because when I hit the nerve, it doesn't go off, and when I'm nowhere near the nerve, it goes off all the time. And the answer is, if you've got it and you've been brought up with it, you should probably use it all the time. But for some of us, I don't get a lot of confidence from it, but I will put it on the patient for the medical legal reasons we've suggested. But I certainly, if I had a patient asleep, wouldn't abandon the case.
A bit like having children, John. You get to if you use it all the time, you recognise the squeaks are important and the ones that aren't really. They are a bit different.
I think that's the important thing. Either use it all the time and become familiar with its use and utility, and also recognise what is artifactual. But the one thing I will say is, amongst the panel and indeed in this room, there are surgeons who have had to fix facial nerves that have been damaged by other ENT surgeons, and the common denominator is, thankfully it's a rare occurrence, but when we have to repair a facial nerve, the one thing that every surgeon says is they do not recall damaging the facial nerve. And I'm afraid a facial nerve monitor won't tell you whether you drill through a nerve. Where it is most useful is when you have revision surgery or you have congenital abnormalities of the temporal bone in cochlear implantation. I think we'll move on from there, and what you can see from there is that I want you to imagine that this is not your scan, but a scan of a very close relative who has right-sided tinnitus and essentially normal hearing, almost normal hearing, and has a lesion in the right cerebellopontine angle which has a maximum intracranial diameter of 12 millimeters. And the question I have for you then is, what advice would you give your close relative in this situation? Let's start in Madrid with Miguel. What would you tell your close relative in this situation?
I don't need to have a close relative. I think we can just speak about the case. It's the same for me. Now, how old is the patient? Can I know?
The patient
the conference is being recorded.
The patient is 48 years old.
Okay, that's a very young man. So, I mean, of course, if this is the first MRI, he can know that he can wait and scan and rescan and see if there is some growth or not, but that probably it will grow and that he will lose chances of hearing preservation. This looks, from the imaging point of view, an ideal case. It's not going into the internal auditory canal, it's just extra canal. But it's tricky. I've lost some hearing in these patients because it doesn't mean that you are going to preserve in 100% of the cases. Of course not. So I can tell him that he has, let's say, 50-60% of chances of hearing preservation, and if we wait, those chances will be reduced. Chances for facial nerve are, of course, very high, close to 100%, and of course, a total tumor removal without any complication. But it's up to the patient, even if it's my relative or not.
So you would offer them either wait rescan, i.e. repeat the imaging, or an attempted retrosigmoid hearing preservation surgery?
Retrosigmoid or retrolab, both of them could serve.
Okay, and what is the chance in your hands of maintaining Class A hearing after this operation?
I think exactly the same, would be below 50%.
Okay,
below 50%. In my hands. In my hands.
So it is the toss of a coin, 50-50.
Yeah.
When you remove this tumor, they will still have that level of hearing. Okay.
Yeah, it's tricky,
I agree, absolutely. Hanover, what is your position in this situation? Thomas, what do you think? Is your microphone on?
Hello? Okay, no. It's okay.
I hear you now.
Okay. Well, it's a young man, and the tumor will probably grow. So while waiting, the hearing probably will deteriorate. That's what we often see. Even so, you can't see a big growth. So I would go for surgery and remove it. And we could also do with the middle fossa. It's still T2 tumor with a better chance for hearing preservation compared to the retrosigmoid. So that's what I would do.
And what chance would you offer the patient of preserving Class A hearing through a middle fossa approach?
For T1 it's 80%. For T2 it's 65%.
Okay, and the risk of epilepsy or a seizure?
You have it, but it's very little. I mean, young men. If you go for older people, then it might be higher. But if it's done correctly, the risk is very low. It's the right ear, so we would go on the right ear. And if it's a right-handed person, then probably it should be. Well, I don't see a special risk for that.
And what if I tell you that the patient is an airline pilot, and if he has a seizure, it's the end of his career?
Well, with a tumor, it's already the end of his career.
Okay, maybe with Lufthansa, yeah, but not with British Airways. Okay, let's go to Antwerp.
Yes, thank you, Jack. I think I would follow the same advice as Miguel said. I would give the patient a choice either to wait for 6 months. I would rescan after 6 months and see if it grows. Then I would propose surgery, and I would do it retrosigmoid, because I think middle fossa here is more dangerous for the facial nerve. At that age, those patients, they want to keep the facial nerve intact, and I think you can do this better by retrosigmoid. I know that the chance to preserve hearing is potentially slightly higher by middle fossa, but I would, in the balance, I would favor the facial nerve to the hearing. So 50-50 chance, yes. But give the patient a choice. Anyway, he can wait 6 months, and you will, by waiting 6 months, you can spot the fast growers. Of course, in the meantime, the patient could lose some hearing, but that's his choice. Either he goes for surgery immediately, or he waits for another scan, and because there are some tumors, even at that age, that will not grow. So if it was my tumor, I think I would wait 6 months. Yes.
Okay, Thomas, thank you very much. And in fact, I'm afraid time has caught up with us, and we have to finish now. I'm going to hand over to my colleagues for the closing remarks. Thank you very much.
I would like to thank all the surgeons. I think there was terrific surgery today, and I think it was very good. And we had a wide diversity of surgical procedures. That was very impressive. I think the quality of the transmission was very good, although we did have a slight hiccup just before 9, but I'm not sure if many people noticed that we had it. I'd like to thank the moderators, John, of course, and Jacques, Rinse, Inge, who did moderation. And of course, I'd like to thank the technical staff that did all the switching, which made it quite amazing. So I like our chief technical guy, Bert, and Eric, who's not here at the moment, who did the technical switching. I need to thank some of the residents that did a lot of setup and work, Mark, Joost, Digna, and all the others that were very much involved. And I must say this was the last Lion transmission as being, for me, as being the president, because we will be electing a new president for the Lion for the next period. So I'd like to thank everybody for connecting and for the nice performance. Hope to see everybody back either for the Winter Lion or for next year's event that we'll do. And I can tell you that we are working on other specialties apart from otology to be transmitted. And I see Thomas waving his hand.
Just okay. For the business meeting, those who are, I believe, stay. That we can do that.
Exactly. We will go right into the business meeting, and I'd like to thank all the participants and hope to see you soon again. Thank you.